Hi, everyone. Welcome to another American Migraine Foundation webinar. My name is Dr. Christine Lay, and I'm currently the chair of the foundation. I'm filling in for Carrie, who's at Headache on the Hill, where many of you may be in attendance as well. I just wanted to thank you for joining us and to remind you that we have tremendous amount of really solid educational material on the website. And there is also a page for Move Against Migraine that you should look into and consider. And it's my pleasure to introduce Dr. Claire Sando, a headache neurologist at University of Toronto and currently the co-chair of our American Migraine Foundation board.
Thank you, Dr. Lay, and good evening, everybody. I think there's been a lot of interest building for this webinar, and I'm really excited to have our great guests with us tonight. I'll just tell you a little bit about the structure of our webinar. As Dr. Lay mentioned, I'm a headache neurologist in Toronto, and I've been having a really wonderful time getting to host these series on women's health. We have a webinar tonight entitled Understanding the Relationship Between Perimenopause, Menopause, and Migraine. We have two wonderful experts here with us tonight, and I'm thrilled to introduce them both. We have Dr. Anne McGregor, who is a specialist in the effect of sex hormones on headache and migraine. In addition to her training on headache, she's also a British Menopause Society specialist and trainer. And we also have Dr. Dina Kuravilla, who is a neurologist, headache specialist, and medical director of the Westport Headache Institute. She has been the chair of the complementary and integrative medicine as well as women's health special intersections for the American Headache Society. I think we're going to have a really lively discussion, and I know we've had several questions submitted already online. Please do keep submitting your questions through the Q&A function. We're going to have about 45 minutes to chat with our experts, and then we'll try to take as many questions as we can at the end. And hope that you all find this as interesting as I'm sure I'm going to. So we're just going to start by defining what it is that we're going to talk about tonight. So Dr. McGregor, could you please just start us off by telling us what is it that we mean when we say perimenopause and menopause?
Perimenopause is essentially when we get to the end of our regular menstrual periods and we're heading into that time of hormone change leading to our last menstrual period, the menopause. On average, certainly in Western societies, starts about the age of 45, and the last menstrual period on average is not until about 52. So you can see there's a good 7 years on average of hormone disruption, where the menstrual cycle can become irregular. We can also sometimes get additional menstrual disorders mixing into perimenopause. And then once we get past the last menstrual period, there's still a wee bit of time where periods have stopped, but the ovaries are still remaining active, trying to work until we get through the complete postmenopause, probably towards our late 50s.
Which hormones are changing over this period? We've talked a lot about estrogen over the course of this webinar series. What's going on with estrogen at this time?
So, contrary to popular belief, through perimenopause, estrogen levels actually become higher. They start to rise as the ovaries are trying to keep functioning. They are more and more stimulated. So we get an increasing fluctuation of hormones, extra estrogen, higher levels of estrogen across the natural menstrual cycle. And coupled with that, we get some cycles where women don't ovulate and they produce less of the natural hormone progesterone, which is often the countering or calming hormone against the brain excitatory estrogen. Early postmenopause, the estrogen levels then gradually start to decline to flat postmenopause levels. There's also often a lot of talk about testosterone, but actually testosterone peaks around our late 20s and gradually declines from there on in and then begins to rise again in our late 60s. So testosterone isn't a natural menopause hormone, but certainly we see these changes in estrogen and progesterone.
That point that you made about estrogen actually rising a bit is going to be really important when we talk about some of the symptoms and changes to migraine that people may experience. So given all of the changes you just mentioned, besides migraine, which we're going to delve into a lot, what other kinds of symptoms might people experience as they're undergoing perimenopause?
So the most typical symptoms people experience are hot flushes and night sweats. And women will often notice them typically just starting before their menstrual periods. And then as the cycles become closer together in the perimenopause, obviously women experience more hot flushes and night sweats, more of the cycle. And then as the cycles get further apart, then hot flushes and night sweats can spread across the whole month. The other common symptoms that women will often mention is disrupted sleep, so that women aren't sleeping so well. They will talk about brain fog with a cognitive dysfunction and will often be quite scared that that may lead to dementia, but that is something we can perhaps discuss in a little bit more detail. Fortunately, there is no link between the brain fog of perimenopause or menopause and dementia. It is part of that menopause transition. But other more subtle symptoms, like sometimes joint pains or muscle aches, are common menopause symptoms that women may not notice. Anxiety is another one, and a feeling of not being in control of things, palpitations, your heart racing very fast. And women just wonder, what on earth is going on? And quite often nobody really thinks about menopause. But hopefully now more people will do.
There's certainly a lot more public awareness, and I think the number of people in the audience today suggests that there's a lot more awareness. So please tell all your friends to watch this webinar after to learn about menopause as well. And I know in my practice, this is something that people come and ask a lot. Is this something that is likely to be impactful to them? And we'll talk about the ways in which it can be both. But Dr. McGregor, what do you tell people about how to diagnose these things? Often people come asking, do they need hormone testing? Do they need other tests? What's your typical advice?
Make a note of all the symptoms. The main key point being look at what's happening to the periods and patterns of hot flushes, night sweats. So looking at patterns often becomes very important when we're trying to make a diagnosis. Symptoms are literally only occurring in the couple of weeks before a menstrual period, and they resolve as soon as the period starts. Is it actually premenstrual symptoms that we're needing to manage rather than perimenopause symptoms? If a woman has heavy menstrual bleeding, is it actually a menstrual disorder that needs to be managed? So we have to be very careful to make sure that we're not putting all of the symptoms into the pot of menopause management. Migraine, obviously, menstrual migraine becomes much more prevalent during perimenopause because with the higher levels of estrogen, there's a greater drop in that time. Triggering migraine is estrogen withdrawal just before a period, but a second mechanism can be also the heavy menstrual periods. So monitoring symptoms, noting symptoms, keeping diaries are all things that help us get the correct diagnosis of the problem.
AMF is going to have a series that's going to deal a little bit with how to track some of these things next month. So stay tuned for that on all of our social media. Thank you, Dr. McGregor, for that nice tie-in. And maybe Dr. Courville, I'd just love to hear from you. Obviously, you're a headache specialist. You have a big interest in women's health. Is this menopause transition something that your patients come and ask you about very much?
People usually come in initially seeking out help for managing migraine disease, but then when we get into more of a deeper conversation, I start hearing a little bit about, my period has been irregular, or I'm starting to sweat at night. I'm starting to have some vaginal dryness. Some people tell me I've been having fertility issues. And there's such a large laundry list of perimenopausal symptoms that can exist. And so when we delve into it and go through the checklist, it turns out that, okay, we might be dealing with perimenopause at this point. It is a very common set of complaints, but oftentimes it's hard to recognize because there's just such a variety to the symptoms.
It's just interesting to note also that many of those symptoms that you just mentioned can be deeply impactful to migraine at any time. And so having all of those things changing seems like a setup for migraine having trouble. So Dr. McGregor, what do you see in general happens to migraine over the course of this period?
Definitely increases during perimenopause, partly because we see this greater hormone trigger of menstrual migraine, so the estrogen withdrawal just before the menstrual period, so a couple of days before, the more hormonal link with migraine is, the better prognosis or the greater likelihood of improvement of migraine with increasing time postmenopause. So I think it is always important for us to make people realize that it is a transition stage. It is not something that you get stuck in forever, and you do come out the other side, even if you do absolutely nothing at all. But the main point is there are lots of things that we can do to help, provided we know exactly what the specific problems are that we're treating.
One really interesting thing that I've seen over the past few years is that these perimenopausal symptoms are happening earlier in some cases. There's this conception out there that perimenopause usually starts in the mid to late 40s, but I have been seeing people having these symptoms earlier in time. Within my practice, I would have to say around 30 to 40% of the people that I see are in some way in a perimenopausal stage. And I do think that the vast majority of people have worsening of their migraine attacks. Another thing I commonly see is that the quality of migraine, or the way that it looks, or what we're used to, changes during perimenopause. So if someone may have classically had a headache here or there, maybe right before their menstruation starts, or when they haven't slept enough, or with a glass of red wine, but then now the quality of the headache has become more frequent, or it's transformed into dizziness, another type of migraine, vestibular migraine. I commonly see that migraine can change and transform during that perimenopausal period. So I try to tell people all the time that migraine can look so many different ways. It doesn't just have to be the headache that's associated classically with sensitivity to light, loud noise, nausea, vomiting, but it takes on many different forms, and that certainly can change during perimenopause.
That's a wonderful point, and it ties in really well with this idea that migraine is not just a headache. There are so many other things that can be bothersome, whether that's during menopause or at other times. Another thing that I've sometimes heard from people is that the timing of their attacks shifts, and sometimes they're closer to the early morning than they used to be. And I'm not sure if that's because of the sleep disruption or something about sleep that's changing in general during that time. I don't know if either of you have seen something like that as well.
There's certain genes that are actually expressed differently. And studies have shown, interestingly, that the body's alarm clock is directly tied to many of the headache disorders that we see, and with migraine. And so in some cases, someone might have an extra, what we call a repeat of a gene that regulates that body's alarm clock. In another case, somebody might have one less, for example, and that can really play into when those attacks are occurring. Many people who are having these migraine attacks during the perimenopausal period oftentimes say they wake up in the middle of the night at the same time with a migraine attack without fail. Between 2 and 3 a.m. is the most common thing I've heard. You know, of course, we want to rule out anything dangerous going on if somebody's waking up in the middle of the night with a headache, but I have to say it's not uncommon to see.
In terms of other things that are happening, I know we've hinted at estrogen going higher and some of the changes that may happen. In terms of migraine with aura, what kind of shifts do you tend to see with aura around the perimenopause period? Maybe Dr. McGregor first. I'd love to hear both your thoughts.
It's a difficult one. We certainly know some studies that we did in the late 1990s where we were looking at women who were starting HRT. We saw that the HRT, as with some of the contraceptive hormones, can in fact trigger off migraine aura as well. Environment is more likely to be associated with migraine aura, and there is some suggestion that this can also occur if there's higher levels periovulatory. So we are more likely to see migraine without aura linked with menstruation. Migraine with aura tends overall to be less hormonally provoked, but can be provoked if there is too much estrogen around. And we are also aware that in general, women postmenopausally may start to experience migraine aura without headache. They might have had a few episodes before when they were very young, but hasn't been particularly prominent throughout life. And that is obviously not associated with hormones. So certainly migraine without aura is very commonly linked to these menopause changes, but not so much, in my experience anyway, with the aura unless you provoke it.
What about you, Dr. Carabell? Is that something that your patients tend to experience?
I certainly think it can be. I'll tell you something. There are really interesting animal models out there that show estradiol itself. Estrogen can activate abnormal electrical activity in the brain, specifically that mechanism of cortical spreading depression, which we know may be a key factor in causing aura. A person might not have had aura or neurological symptoms as a manifestation of migraine, and now they may be having some aura attacks. Some visual aura most commonly is what I see in the practice. So I certainly think there's a link there, and I agree with Dr. McGregor that it really can be triggered in some cases.
So I guess there's a lot of variety from person to person as well, which is true of migraine at any other time of life. We have hinted at the next topic I'd like us to touch on, which is hormone replacement therapy, or HRT, because this is obviously a huge area of research and interest for patients and doctors. I get a lot of consults about safety of HRT for my patients. Dr. McGregor, can you tell us just a little bit about the sort of risks, benefits of HRT in general before we talk specifically about it with respect to migraine?
Replacement therapy is, as its name suggests, it should be used to replace hormones that are no longer being made, which is very different from supplementing hormones that are already there. So it was developed to be used for the management of hot flushes, night sweats in postmenopausal women, was its original concept. And it is essentially replacing the estrogen that postmenopause is fluctuating sufficiently to still cause these symptoms. I mean, this is back in the late 1930s, early 1940s. We're talking about many, many years ago. They quickly realized that while the estrogen benefited all the symptoms, that too much estrogen then stimulated the lining of the womb and could potentially lead to womb cancer. What we've now discovered is that if we use body identical progesterone, micronized progesterone, that can, to a small extent, counteract the brain excitatory effects of estrogen and can have a potentially brain calming effect on migraine as well. But we're still in very early days of looking at this different perspective of hormone utility beyond just menopause symptom management.
And I know there's been a fair amount of buzz over time about some of the other risks, so cancer risk or dementia risk.
Yes, so sorry, you did ask about that, and I segued slightly off the topic. The HRTs, hormone replacement therapies that we use now, particularly the transdermal ones, means that the estrogen is going through the skin, are incredibly safe. There used to be concerns about making blood more sticky and increased blood clotting risks with some of the oral estrogens. But that has become less and less over time with the types of hormones that we currently use. From the benefits, long-term use of HRT can not just benefit menopause symptoms, but can help with heart and bone health too. The downside is that there is a duration-dependent potential increased risk of breast cancer, but that has to be put on the background that about 1 in 8 women are likely to develop breast cancer anyway, because that's a background risk. So obesity, women who have a body mass index of over 30, that actually doubles their background risk. Using HRT is equivalent to probably a woman drinking a couple of glasses of wine every night, if we look at that as potential risks. So it is very much, you can never say so much what are the risks and benefits overall. You have to look at it from the person's individual perspective. What are the benefits and what are the risks for you?
I love that both of you are highlighting the individual nature of these choices and the way that they impact people. And so to ask a broad question, is HRT good for migraine?
No. That's the rub. It is something that I have found increasingly troublesome, and I would very much like to hear Dr. Buravilla's opinion on this as well. But I used to be of the opinion that maybe if we used HRT in perimenopause, it might help balance out the hormones and stop the dips and so on. My experience has increasingly been that it just adds to the already fluctuating levels of hormones there, and meant, while a few women might benefit, the more common story I hear, particularly if HRT is instigated too early, is that it just adds on top of these high levels of estrogen. Women get more headaches and they get more migraine. If we look at it from the post-menopause perspective, all the science shows that HRT increases the risk of experienced migraine. That's not to say that women with migraine can't take HRT, but it is very much, you need the minimum dose of hormones to manage the menopause symptoms without aggravating the migraine. And increasingly in perimenopause, particularly because women often have a lot of other menstrual disorders or premenstrual symptoms and so on as well, I tend to increasingly go for hormone methods that are cycle suppression. So suppressing the natural hormones and putting them back at stable hormone levels rather than using HRT, which adds to that hormone chaos.
Dr. Perville, what's your experience? Do you think we should be using HRT to target migraine?
I don't think so. The use of estrogen and migraine frequency and severity have been conflicting. And the World Health Organization and our national headache societies, international headache societies, have recommended starting off with mainstream migraine preventive treatments and as-needed treatments before considering hormone replacement therapy. I have had people that I've seen in the practice who tried hormone replacement therapy before they came to me for headache management, and not just for migraine in particular, but also the other symptoms of menopause, for weight gain, hair changes. And in many cases, what I hear is that many of the non-migraine symptoms improve. But when it comes to migraine, that was the one thing that didn't get much better. So oftentimes we do have to reach for our classic migraine preventive therapies and as-needed therapies.
Maybe just one more question, because I think this is an area where I get a lot of questions. I'm sure you do too. Does the type of HRT that you're suggesting make a big difference to those recommendations? So pills versus, Dr. McGregor mentioned, the skin patch versions versus something like vaginal estrogen?
You need to separate out what we call systemic HRT from vaginal estrogen. Vaginal estrogen, very little of it gets into the bloodstream. What would be wonderful if every single postmenopausal woman actually used vaginal estrogen, because it has benefits to protect against bladder problems, urinary tract infections, not just vaginal problems or vaginal dryness as well. There are huge advantages to women as we age to use vaginal estrogen. What we're really talking about here is a systemic estrogen, where certainly the shift from a pure safety perspective is to use the transdermal estrogen, such as the patches, the gel that you can rub on your skin. And certainly in Europe, we also have a spray that you can use for estrogen as well. Preference for the progestogen is we're tolerated to use body identical micronized progesterone, but that is not always so good at preventing unscheduled bleeding, particularly in postmenopausal women. The big difficulty is in the perimenopausal woman, because we actually have no clinical trial data looking at migraine when HRT is used in perimenopause. Any clinical trial that has been done has been in postmenopausal women where their periods have stopped. So from the safety perspective, I certainly always use that combination, or using for the progestogen component that can also be very helpful in perimenopause is the hormone intrauterine device. as well. But it is difficult. I completely agree with my colleague, is we should not be using HRT to manage perimenopausal migraine. We should be looking at managing the migraine and using the hormones to manage the hormone problems.
Dr. Kuruvilla, what should we be doing to manage migraine during this time? Maybe we can start with some of the medication options that are targeting migraine rather than the hormones.
Sure. So I'll start off by saying one thing that a lot of people are surprised to hear is when to consider a preventive treatment or something to cut down on the overall number of headache days and reduce the overall disability. And that threshold is somewhere around where you might need a preventive treatment is somewhere around 4 or more headache days a month. And so most of the people that I see are kind of lingering above that, 4 or more headache days a month. I might tailor the treatment specifically for people who have a specific perimenopausal symptom. For example, night sweats and hot flashes. I might consider 2 different medications that are used kind of off-label for hot flashes, night sweats, and also can be considered for migraine prevention, which are venlafaxine and gabapentin. Venlafaxine is an antidepressant medication, and gabapentin is a seizure medication that's also used as a nerve medication. Both of those have been looked at in very small studies also for night sweats and hot flashes, so I might consider those. A natural supplement that has a clinical trial behind it for hot flashes and night sweats and also migraine prevention is black cohosh. It's a supplement that's a derivative of estrogen. So that may be considered too if somebody was considering a more natural approach. But really, any of the mainstream migraine preventive therapies work in this population. Our calcitonin gene-related peptide preventive treatments that are available in tablet form and injectable form and infusion form. We have several blood pressure medications, seizure medications, and other antidepressants that are also very helpful for the prevention of migraine, as well as Ana-botulinum toxin A. And I always tell everybody having a preventive approach to migraine is important, but also the as-needed approach. Because we know if we don't stop a migraine attack in its tracks early on, sometimes those attacks can last a whole day or several days in many cases. So we really want to have a plan A, a plan B, C, maybe beyond that for as-needed treatment when you have an attack. So the medications that we typically use in this category are nonsteroidal anti-inflammatories, another family called triptans, which were developed specifically for migraine as-needed treatment in the 90s. And also our GPANs, or also those calcitonin gene-related peptide medications. And so those are really the considerations to start off with. And every toolkit should really have a preventive approach in some cases, definitely as-needed approaches to really help in an emergency. And then also some lifestyle approaches or natural approaches can be considered too.
And you are a huge expert on some of those more natural, integrative kinds of approaches. Do you have any specific ones that you recommend in the context of perimenopause, menopause?
Absolutely. I've seen a lot of success with cognitive behavioral therapy, specifically working with a therapist, a psychologist to diary, to document sleep, eating habits, mood changes, and really working with somebody one-on-one to tailor your lifestyle and retrain the brain. So that would be cognitive behavioral therapy. There's also biofeedback and relaxation, where in some cases you may be hooked up to an electrode or an electrical stimulation device in different areas, like the shoulders, for example, and learn how to use your breathing and kind of calming down the body and learning how to calm the muscles. That's just one example. So those are some mind-body approaches. There have been smaller studies that have backed up yoga, Tai Chi, definitely aerobic exercise is a big one. Certainly there's many mindfulness meditation studies that have come out, so that a lot of those mind-body approaches can be helpful. Acupuncture has been studied in clinical trials. Sacral therapy, where movements are done specifically within the head and neck region. Certainly nutraceuticals. There are vitamins that have been studied for lower frequency of migraine per month for prevention, such as magnesium, riboflavin, coenzyme Q10. Vitamin D is a big one here in the Northeast where we don't get much sunlight. And there's a number of different supplements that can be considered like that.
I like vitamin D here in Canada too. We definitely need that. And I do think that the magnesium piece can be helpful with some of the sleep issues too, in particular during this time, in addition to helping migraine in general, which it sounds like the key point is treating migraine as best we can is the best way of treating migraine. Dr. Corbell, any special safety considerations you have?
I just wanted to add one more thing. You mentioned sleep. Sleep is a huge complaint during the perimenopausal period. And so another option I just want to mention is melatonin. Melatonin, I think, is very underutilized in general within practices. I do think it could be helpful if it was used in very small doses and maybe increased optimally. So I'll put just add that comment about the sleep. Things to look out for. So the most common cause of death within this population and beyond in postmenopause is heart attack. And so the aim of the game is to really optimize the risks that a person might have for heart disease, specifically heart attack, stroke, and other related diseases. And so in many cases, if we're considering a preventive prescription medication, we want to take into account what the blood pressure looks like. What does the cholesterol look like, that bad cholesterol called LDL? What does the hemoglobin A1C show, which is a diabetes marker over time? We want to make sure that we're picking the right preventive options that are going to complement any cardiac risk factors, because in reality, heart disease is the most common risk of death in women and the thing that we see most commonly. So that's something to certainly monitor for. And to also, I can't highlight enough the importance of partnering. My partnerships with the primary care physicians, the cardiologists, and specifically my OBGYN colleagues. I have all of them on speed dial, and we're often working together on that treatment regimen.
One of my next questions, Dr. McGregor, who should be on the team of somebody who is dealing with migraines? Is it their headache specialist? Do they need an OB? Who should be on the team?
I think that depends very much on countries, and I'm probably not the the best person to answer that for what goes on in the States. But I would very much support, as part of that team process, the people who manage the lifestyle. Yeah, I completely agree with my colleague. You cannot not look after yourself during perimenopause, and particularly with migraine as well. Cognitive behavioral therapy, we also use as a menopause management strategy too. So many of these things that she's saying are strategies that work across the spectrum. I mean, it is very much finding people who will work together as a team to help you. It's not helpful to go to one person who's going to look at your migraine who has no clue what is going on with your menopause management strategy. So it's not so much which are the specialties that deal with it, but who are the types of people who can help support you through that journey.
And I love this point. Migraine doesn't exist in isolation. And so you are a whole person. Migraine is one of the things that with which you live. Dr. Kuruvilla, who do you get on your patient's team during this time?
I certainly partner with the primary care physician as the central person, psychiatry, psychology, OBGYN. In many cases, I have a cardiologist on board because there are a lot of medication adjustments that are being done and cardiac heart workups that are being done there. And in many cases, there may be a rheumatologist. Migraine can coexist with other autoimmune diseases, so sometimes you might have to have a rheumatologist involved. The bottom line that I would say is that whoever is a part of your care, as Dr. McGregor said, they should be working together. They should be on a similar path together and not working separately from the others. if you are seeing somebody that says, I don't need to know what that other person is doing, that should automatically be a red flag.
And so I would encourage anybody who doesn't currently have a headache specialist at the Quest to use the AMF Find a Doctor tool on our website to try to help connect with headache specialists in the area. I'm sorry in advance, we have a lot of questions. Some of them we probably won't get to, but we'll do our best. So first question, can we talk about the influence of hormone changes on vestibular migraine and differentiating this subtype? This is for whoever wants to take this.
I'll start off because I think it's something that we can both address. I think it's this link with vestibular symptoms is something we should be taking more notice of as a perimenopausal symptom. We do see a lot of people who get referred off to ear, nose and throat specialists to get a workup because they're suddenly experiencing dizziness and vestibular symptoms in their 40s, and there's no doubt that there will be an estrogen component. In my experience, we don't know the best strategies for managing it yet. We need a lot of research into the effects of estrogen on the vestibular symptoms. That's my take on it, but it's definitely a problem in perimenopause.
I have to agree. A lot of people may develop vestibular migraine for the first time during perimenopause and had a completely different type beforehand. Or the baseline symptoms may have gotten worse during perimenopause. The treatment certainly doesn't change. I always partner with an ear, nose, and throat physician to do a full exam and clear another issue from going on, make sure it's not another issue. Like benign positional vertigo is a common one, or Meniere's disease or other things. But I would have to say most people that I see with vestibular migraine do respond to mainstream, the classic migraine preventive and as needed treatment.
I think I had a couple of patients today alone who I think had this happen to them around menopause. It certainly seems common here in Canada too. So next question, which we've touched on, but maybe just to flesh this out more clearly. So how do you recommend approaching HRT in people who have aura? Should they be avoiding estrogen? And does the amount of aura that they have influence your decision?
My personal take is, provided you are minimizing you're checking out their cardiovascular risks, you use the lowest effective dose of transdermal estrogen and either a transdermal progestogen, a Mirena, or micronized progesterone. None of those increase blood clotting or blood stickiness. And then it is really down to, if they're using hormone replacement therapy, you monitor that there is no change in their aura frequency. And if there is, you adjust the dose of the hormones. And if the hormones clearly become an aggravating factor, you look at managing their menopause symptoms with non-hormonal strategies like venlafaxine, for example, as some of those, and black cohosh. And CBT as other options, which may well also help the migraine.
Go to those hormonal options if needed for other menopausal symptoms. And if, that's kind of we've tried everything else, and this is a path that we may want to consider with our OBGYN colleagues. But I do exactly the same thing. I would advise my OBGYN colleagues to use the lowest dose possible of estrogen in this population and monitor them very closely.
Yeah, and helping our colleagues also to keep in mind Dr. McGregor's point about this being trying to get you back to the estrogen level you used to have, which you had all your life before we gave people hormones.
The point here is the importance of making the correct diagnosis of periovulatory migraine without disputing what a person's perception is. Many women do get confused and think that ovulation occurs in the middle of the menstrual cycle, and that is not the case. It occurs roughly about 14 to 16 days before the next menstrual period. So if you have a routine 35-day cycle, for example, you don't ovulate in the middle of the cycle. You're ovulating 3 weeks after your last period and 2 weeks before the next one. No studies so far have identified that ovulation is a statistically increased risky time for migraine. However, at an individual level, There may be some women who they identify the time of ovulation and they do find consistently that peri-ovulatory drop in estrogen may be a sufficient trigger for them. But in most cases, it seems to be that you have to have a sustained high level of estrogen, as in the second part of the menstrual cycle, before the drop.
And that gets back also to the points about diaries being really important and helpful for determining
Absolutely.
all these.
It is very difficult to manage women without diaries.
Here's an interesting question. This one actually came up several times in different versions. So what about a hysterectomy? Is that something to consider to treat migraine? There's a lot of head shaking here. Go for Dr. Kirby.
I would usually advise no. And I'm assuming that you mean total hysterectomy, where both ovaries are removed and the uterus, but we don't recommend that specifically for the treatment of migraine. I oftentimes see the opposite in my practice, where people have undergone hysterectomy, actually had a peak in their migraine attacks over the next couple of years.
Absolutely. I think you don't want to remove healthy ovaries, because even post-menopause, there is clear evidence to show that your ovaries still benefit your general well-being. So it's not that they become totally redundant post-menopause, they are still doing something. And there are clear scientific evidence to support that. So if you have diseased ovaries, or there are general disorders that require either the womb to be removed and or the ovaries, then obviously these are strategies that we will then manage the potential consequences of. You still have a natural hormone cycle triggering off an estrogen withdrawal migraine. It's just not linked to the obvious period. So it's not a good way to go forward.
And other than HRT, are there any other suggestions for, this person is asking, balancing hormones?
I think my colleague has mentioned several already. I'm quite a fan of Agnus Castus for women who have mild perimenopause symptoms. So Agnus Castus is a very long-standing supplement, herbal treatment that women used to use to balance out their hormones. And some of my patients have found that is just sufficient for them. The other one is diet. We can go a huge way balancing out hormones by just having a good, healthy, popular Mediterranean diet, which has got lots of plant-based estrogens in it, and that can make a huge difference at helping hormones through the menopause transition.
And another hormone-targeted question. Do you find that the progesterone IUDs have a negative or positive impact on migraine?
From my perspective, it depends what you're using them for. So while we talk a lot about estrogen withdrawal being a correlation between women who experience heavy menstrual periods, who will then often get migraine attacks with their menstrual bleed, or even just at the end of a heavy menstrual bleed. And that is due to a hormone called prostaglandin. If we gave injections of prostaglandins to anybody, they would get headaches with nausea and vomiting, just like a migraine. So if you manage the menstrual disorder, which can be very successfully done with the hormone intrauterine system, that can, in some cases, also benefit the migraine. And in a small number of women, the hormone sufficiently within the first 9 months or so after it's fitted can be sufficient to put the ovaries into hibernation temporarily. So we're back to exactly what we've all been saying throughout the whole webinar. It's very individual.
Dr. Purville, what's your practice there?
Replacing the progesterone helps with the vasomotor symptoms specifically. That's what patients report to me in many cases. I'm going to sound like a broken record, but I always go back to the mainstream migraine approaches. Dr. McGregor mentioned diet, and I think there's a lot of misconceptions regarding diet. One of the most common questions I get in my practice in perimenopausal, postmenopausal women is a specific magical migraine diet I can follow. Am I going to be able to heal migraine by getting rid of all gluten? Am I going to get rid of it by getting rid of one specific factor or two specific factors, or reading this book that was guaranteed to heal migraine? So I'd say the bottom line is there's no cure for migraine. Specifically, it is a disease, but the two diets that have some clinical evidence behind them and studies behind them, one is the Mediterranean diet that Dr. McGregor mentioned, and the other is the keto diet. You know, with that said, though, the keto diet is quite difficult to follow. And may not be a great idea in people with high cholesterol, high blood pressure, diabetes. That may end up being an issue. So the Mediterranean diet really is helpful in that case.
Thank you. And Dr. McGregor, any other diet points to highlight?
There is so much in social media, and so you should not eat this, you should not eat that. That's going to help your migraine. And unless you have very clearly identified a very strong link between every time you eat something and it triggers off a migraine. In general, most people with migraine are able to eat everything normally. The important thing is keep the brain well fed. The migraine brain likes its energy. It needs to be well energized. We need to be less restrictive and more open in what we do to migraine. We tend to be much more, you can't do this, you can't do that, whereas it should be, you can do this despite your migraine.
We are kind of at time, but I'm going to ask for a 10-second, if possible, take-home point from each of you for today, Dr. McGregor.
HRT and hormones are not there to treat migraine. They are there to treat hormone problems, and migraine treatment is there to manage migraine.
Thank you. Dr. Kurvila?
Seek help as soon as possible when you start experiencing any suspicious symptoms, whether it be symptoms related to migraine or other associated symptoms like weight gain, breast tenderness, hair changes, palpitations, and really express those to whoever cares for you for migraine, so that you can come up with a plan that includes preventive approaches and make sure all of your clinicians are in the same loop.
Thank you both so much. This was a great, broad-ranging discussion. This recording is going to be hopefully available on our events page in not too long. Thank you so much to everybody who attended and for all of the thought-provoking questions. We will hopefully see you next time on our future webinars. Thank you again.